Hello, I'm Larry Tanenbaum, and welcome to the floor of RSNA 2024. I'm thrilled to have the opportunity to welcome you all here to this Applied Radiology Roundtable series on the latest trends in Alzheimer's imaging and management. For this module, a call to action, obligations for neuroradiologists and the enterprise, I'm joined here today by Dr. Petrice Cogswell, who's an associate professor of radiology at the Mayo Clinic, and Dr. Suzie Bash, who is from RadNet and he was the national lead for all of Alzheimer's imaging and dementia imaging, as well as quantitative imaging. Dr. Bash.
Thanks for having us.
All right, so let's get into it. There's a lot to discuss today. This is one of the areas that I have the greatest passion about in this area of dementia imaging. My co-panelists are wondering what happens when I have too much passion, but let's just move on. Can one of you just sort of give me a sense of where we're going to get started? Talk to me about the disease-modifying therapies. What are they, and the rest of the background. Who's going to take that one? Great.
I'll go ahead with that one. So the disease-modifying therapies for Alzheimer's disease, the general field of therapies are immunotherapies targeting beta amyloid.
Okay.
They can remove amyloid from the brain. There's currently 2 that are approved by the FDA, and those are lecanemab and donanemab. And those agents have shown to provide about a 20% slowing of cognitive decline and a marked removal of amyloid from the brain. So patients who have amyloid in their brain before starting therapy will have amyloid removed to the point that on a PET scan they would be considered amyloid negative.
So it's all based on the theory that amyloid is a causative agent here, and removing them improves therapy. Is there any stratification as to how patients will do, say based on how much amyloid or how much tau they've got?
So that is a good question, and
I have a few of those.
that is yet to be answered. So in terms of the amount of there's some data showing so far that patients who are more advanced in the disease process, so more tau in their brain, don't do as well, so that targeting patients earlier, those patients will have the best response to therapy in terms of the slowing of cognitive decline.
And actually, when the Clarity AD trial, when they looked at their data, they found exactly that. So when they did sort of a sub-study analysis of the low tau group patients, they had much better clinical outcomes than the 20% that you just reported. So actually, 76% of those patients had no cognitive decline at 18 months, and 60% actually had cognitive improvement at 18 months when you catch them in the earliest stage of disease, in other words, the low tau state.
All right, that's great. So the therapies sound wonderful. Are there any risks associated with these therapies?
So unfortunately, with monoclonal antibodies that target beta amyloid plaque, you have the risk of amyloid-related imaging abnormalities, or ARIA. So there's ARIA-E, which is edema or focal effusions, and ARIA-H, which is microhemorrhage or superficial siderosis. Now, the majority of patients won't even know that they develop ARIA. So, for example, with Leqembi, only 3% of patients have symptomatic ARIA, and it's a little bit higher for donanemab. It's for Kisunla, it's 6%. So again, most patients don't know, but it's still critical to be able to identify the ARIA when it does occur, so that the infusion can be held if it's moderate or severe in degree radiographically. Because what you don't want to do is dose a patient on top of a moderate or severe ARIA and then potentially have it get worse. Now, ARIA can get worse on its own anyway, but ARIA-E, the good news is that it essentially almost always resolves by 1 year, and then the ARIA-H will become stable. And in my experience, these patients are they notice the benefit of the drug and are actually anxious to restart it once their ARIA has resolved. But again, for neuroradiologists, it's very, very critical that we find the ARIA, grade it correctly, and communicate that back with the referring neurologist so that they can hold the infusion if they need to.
So it's an interesting thing because, there are the 2 approved drugs that we mentioned, and it does seem to be a trend that when the efficacy goes up, the complication rate goes up. It's really kind of exciting to hear the recent news that when you adjust the dosing regimen for Kisunla, the complication rate sort of settled down to about where it was with Leqembi, which is really exciting because there are more drugs coming. They do promise perhaps to be more effective, but they also promise to have higher risks. So it'll be interesting to see how that plays out. It's good stuff. So does either one of you want to talk about why we get edema and hemorrhage when we mobilize amyloid?
So the edema and hemorrhage are thought of ARIA are thought to be of a similar pathophysiology to cerebral amyloid angiopathy-related inflammation. So the exact etiology of ARIA is unknown, but there's thought to be multiple factors. So related to the removal of amyloid from the vessel wall, as well as the parenchyma, with the amyloid removing therapies, and that can create, sort of, say, leaky vessels. It is also thought that as the amyloid is removed from the parenchyma, some of that may deposit back into the vessel wall, and hence a worsening of cerebral amyloid angiopathy.
Because early on, the predominant concentration is in that perivascular space, the periarterial space. So I hadn't really thought about the fact that after you clear it, it's gonna fill in where the other one goes, and attack a vessel that may very well be already inflamed and leaky. I think that's really a good way to describe that and to help understand that. All right, so let's go one step further. So we talked about the therapies, we talked about the risks, and I want to expand more on what ARIA is in a moment, because that's really where the focus of this session is. But let's start out with, you're doing the MR. You're going to give these therapies, which may cause these edema and hemorrhage. What are we looking for? Either one of you, or both of you.
Oh, I can start. So a baseline MRI is required prior to starting therapy. And the key components of the baseline MRI interpretation is identifying any baseline microhemorrhages. We know that patients with Alzheimer's disease are more likely to get cerebral amyloid angiopathy. We don't want to start a patient on therapy and miss those microhemorrhages. And it's not just about finding a few, we actually need the actual count. It's extremely important to know the baseline count of microhemorrhages.
Why is that important?
Because what we don't want to do is neglect to mention baseline microhemorrhages and then have the patient come back and get an ARIA interpretation or surveillance study, and now we're mentioning all these microhemorrhages, and we don't want to attribute that to the drugs if it was already present at baseline.
Let me just take you back one step. For a simple-minded guy, why do I care how many hemorrhages there are on the baseline exam?
Well, because the neurologist may not feel that the patient is a good candidate for therapy if they have a lot of baseline microhemorrhages. Now, the clinical...
And even macrohemorrhages too, right? If they have a diseased brain that maybe has had a lot of strokes or prior hemorrhages,
right,
it's important.
And in that, those are findings that increase the patient's risk for ARIA. Right. And that, existing,
so that's a very important piece,
that existing microhemorrhages or siderosis it puts the patient at increased risk of having both more microhemorrhages and siderosis, as well as edema with
because that part doesn't get as much coverage because we're always focused on ARIA, but I think it's important for the neuroradiologist to understand what the criteria are in those, what we're looking for in those circumstances, which I think is very, very important. Talk to me about the surveillance examinations, what we're looking for, how important is it to, how important is it for us to do our job properly?
So on the surveillance MRIs where we're looking for ARIA, so we're looking for findings of new edema, a new sulcal effusion, new microhemorrhages and siderosis since starting therapy. And to do that, we need to have a high quality brain MRI. They're preferentially performed at 3 Tesla. And we need to have the appropriate sequences. So we need to have a T2 flare to look for ARIA-E, and a GRE or SWI to look for the ARIA-H microhemorrhages and siderosis. And to do this well, we ideally perform the imaging in a consistent fashion across the serial exams in a patient.
Great. So there's a few things I want to pick up on. As you know, I was once an administrator for a large imaging organization. We had about a third 3T scanners, but not all of them, with 3T. So, while it might be nice to prefer a 3T, it's kind of difficult to accomplish in the community. And also, while it might be great to be sticking on a 1.5 or a 3T, sometimes you got to go where the patients can go, and sometimes that means a 1.2 Tesla scanner. And in some settings, when you start talking about going to unusual settings, it might mean a 0.5 Tesla scanner or a 0.06 Tesla scanner, which will be very interesting to see where that actually goes. So you talked about what we have to detect, but I don't understand, I'm playing like I don't understand why it's important to count and detect all of these lesions. Are there some rules that I need to know about whether therapy would be paused or continued?
Yeah, so it is important to have an accurate count, but getting back to what you were saying before as well, the protocol is extremely important. For example, we were talking here about a GRE or an SWI. Again, the parameters, standardization is really ideal when it comes to screening these patients. In an ideal world, they come back to the exact same scanner of the exact same strength, but that doesn't happen in reality, as you were just mentioning. But what is very important is that we make sure our protocol parameters are in place. So, we need to make sure that the TE is correct. So ideally on a 1.5 scanner, we want that TE around 30, on a 3 Tesla around 20. If the TE is set too low, you will miss the microhemorrhages. And so anticipating operational issues that could happen if a patient came in and they were scanned on a 1.5, the TE was only 5, and the microhemorrhages were not caught on the baseline MRI. Now the patient comes back, they're on a different scanner, maybe a 3T, and now the TE is set correctly, and you've identified now 6 new microhemorrhages. The problem is that ARIA, or was it due to improper technique at the baseline MRI? So again, that's why it's very important for imaging enterprises to have, to really think about this, have set protocols in place, and scan their dementia protocol the same way each time, and preferably with a 3D T1 input as well, so it's quant capable.
So what I was trying to tease out of my panelists, and now I have to do myself, is that there are criteria for whether therapy can be continued or has to be paused, and it's based on the grading and severity of these findings. So it's really important that we do this properly, we be tuned in to the appropriate inflection points when therapy is changed, and communicate that effectively. You mentioned, Dr. Bash mentioned that if you're going to use gradient echo, which is sort of the baseline way we've detected hemorrhages for generations, that the parameters are really important. And I see that across the nation, that's one of the areas where we fail. Even when I was in charge of the imaging enterprise, we fail. So it's very, very important to pay attention to that. But as long as I have zealots here at the table with me, let's do the quick discussion on GRE versus SWI. What's your opinion? And then Petrice will let you go ahead.
Yeah, so at RadNet, we've decided to use the GRE for all of our dementia protocol cases. And that's because that's what they used in the trial, and that's what the ARIA grading scale was based off of. So we know that the SWI is more sensitive for picking up these microhemorrhages, but we don't encourage use. We encourage just the GRE if possible. Now, if the referring doctor wants an SWI, we'll do that as an add-on to the GRE, but we always do the GRE so that the grading is consistent and matches the scale. Truthfully, the grading system would need to change if it was for SWI. So it was based on GRE, so that's why we do that. And the problem with doing both a GRE and an SWI is maybe the SWI picks up a couple more microhemorrhages because it's a more sensitive technique than the GRE, and then it kind of muddies the waters with our reports, So we're saying, okay, this is the number of microhemorrhages I see on GRE, this is the radiographic ARIA grading, but this is what the SWI found. It's just not nearly as clean of a report, and that's why at RadNet we've decided to do that. But again, consistency is really what's paramount. So what's been your experience?
So we are doing right now an SWI and a GRE for both the baseline enrollment scan as well as ARIA monitoring. Some of the radiologists have asked, so then what do I report? Do I say, do I report on both of them? And we've said, report on what is the true number of microhemorrhages. And so I think it has been interesting to see, how the microhemorrhages appear on the SWI versus GRE. And sometimes there are, rare cases where on a GRE you can more definitively call this, or that it is a microhemorrhage, but
as opposed to a blood vessel, yeah. And that's the part we don't usually think about because it's a little more challenging to interpret an SWI. So I'm very interested in your perspective. So while in any given visit you can establish, we know that SWI is more sensitive, maybe a bit less specific, you can use whatever baseline you like, except that when you get incident changes in the interval, and the rules and guidelines that we have as they exist are based on the lower sensitivity GRE. Let's say for a theory, you have no microhemorrhages on the GRE incident from the last exam, but now you've got 3 microhemorrhages incident seen only on the SWI. How would you react to that? And let's say that wasn't 3, let's say it was 5. Get over the threshold for you may want to change. You can see 5 new ones on the SWI, but only 2 maybe on the GRE. How would you deal with that?
How would you grade the ARIA?
Right. Well, I think so. Our neurologists are very on board with a conservative approach. So they would want to overreact than underreact to something, and they are cautious in following up microhemorrhages, even if it were 2 or 3, to follow those and make sure that they are stable. So they right now want to go off the SWI findings or whatever it is that you think are the real number of microhemorrhages. They want to be as sensitive as possible.
And so would they hold the infusion if the SWI got you over that 5 threshold, but the GRE didn't?
Yes, they would go. They would, they'd take the whole picture into context, but they would manage based upon the SWI for the time being. Yeah.
So I only have really time for one more topic, and that is about interfacing with neurologists and other shareholders in the treatment pathway. Can you talk to me about, the Mayo Clinic is a good place, with an integrated health system to have this question, multidisciplinary patient management. What do you do when the genetic testing points to 1 or 2 alleles, of the E4? Do you do the genetic testing in your institution? Because I've seen in some academic centers it's becoming required. When we first started this, it seemed to be more optional. Talk to us about that.
All of the patients that go through our Alzheimer's disease treatment clinic for evaluation, they all get ApoE genotyping. And we have a weekly multidisciplinary conference in which we talk about their neuropsychological testing, their imaging biomarkers, and their ApoE status is incorporated into their risk-benefit discussion. And that is, so we talk about that at conference, and then they integrate a number of microhemorrhages and their ApoE4 status to the biggest risk factors for ARIA into the risk discussion, and that risk discussion we'll have with the patient.
So 2 questions. Is there a strict formula that you follow? Or does it become gray areas and that kind of discussion?
There are definitely gray areas. We're not treating ApoE4 homozygotes at all until more recently, and are taking a more cautious approach with that. But they'll take it into context, knowing that 4 microhemorrhages may still be eligible for therapy, but at greater risk than 2 microhemorrhages. So again, part of the risk discussion with the patient.
Would you just clarify for me, because I'm fairly naive about this, who is in that multidisciplinary conference, which disciplines?
So it is the cognitive neurologists who see all the patients, the neuropsychologists, neuroradiologists, and nuclear medicine physicians. And then there's also social workers and I think other parts of the allied healthcare team who help with the patient care pathway.
Yeah, I think it's wonderful that this type of multidisciplinary tumor board, so to speak, exists and it is guiding therapy in these patients. Well, I think this is as good a place as any to wrap up our discussion on a call to action, obligations for neuroradiology in the enterprise. I'd like to give great thanks to my panelists, Dr. Suzie Bash, Dr. Petrice Cogswell, for joining me in this roundtable series in the latest trends in Alzheimer's imaging and management, being hosted by Applied Radiology with sponsorship from Siemens Healthcare and AgoraCare. Thank you very much for joining us.
Thanks for having us.
Thank you.